We have Dr. Heger, we actually met each other, how many years ago is that now? Is that like so 1990, I guess, 1991, something like that.
Scary.
It's scary. I don't want to think about it so much, but that was actually the year that my son was diagnosed, and that's why I ended up over in that area of the world. So, in any event, he comes from SUNY downstate, way back when, and then moved to, so help me with this. Come up and help me. Yeah.
Turn this on.
Yeah.
Yeah. So, yeah, after my time in Brooklyn, we went over to Philadelphia. I did my pediatric fellowship there. Then it was down to South Florida, which is sort of like New York, but with better weather, to start my pediatric career, and then moved up to Jacksonville a few years later. And after a few years there, now I'm up here. So it was a good way of tempering myself going up the Florida coast to here. I think it would have been somewhat of a culture shock being born and bred New Yorker coming here, but it's been working out.
It's working out. And so my one question going in is, why Chiari?
Why Chiari?
Mm-hmm.
Well, I think the real question for me would be why not? You know, from the moment that I graduated from college, even before medical school, I was thrust into the Chiari role, whether I liked it or not, as things worked out working at SUNY downstate. So, I mean, there aren't many people who are involved in Chiari around anymore, that is, who can say they've been involved in this for almost 27 years. You know, everywhere from the, you know, bench research, you know, to patient care. It was a very large part of my residency training, and you know, I tried to move past it for a period of time, but you know, I think it's important. I know enough now, and I think based on my past experience and now my current experience, I think I have a unique perspective, and I think I can make a good contribution. So, you know, I do this to help people every day, so I think this is a really good opportunity to help. And you see patient stories like that. You know, that's one story. I got dozens of patients who have that same story. It's very compelling and very motivating.
So let's welcome Dr. Heger. Thank you.
Okay, let me pop my talk up here. So the good thing about this talk, once I can find how to. There we go. The good thing about it is, you know, this was initially written for pediatricians. And what's good about that is because they know very little about Chiari, it's sort of, I think it'll be very digestible for people without a medical background. Although I would also say people who have to live with Chiari sometimes are probably better educated than doctors anyway. So if this goes a little bit above you, I'm sorry. If it's dumbed down too much, I'm sorry for that as well. The point that I want to, there's going to be a lot of information, but what I also want to get through, the overarching thought about this is, traditionally the Chiari centers has basically been neurosurgical focused, and really you go to the Chiari center to find out if you're a candidate for surgery or not. If you're a candidate for surgery, great, you have hope. If not, you're out of luck. But I think going forward we need to change that concept of what a Chiari center is, and obviously neurosurgeons are going to be a very large part of that. However, it shouldn't be centered around neurosurgery. It should be centered around what the patient needs. So I'm open to suggestions of conflicts of interest if anyone. So I'm going to be talking about, Chiari malformations, and connective tissue disorders, how they work together, and why it's necessary to have this team-based approach to really care for patients properly. So let's back up, start at the beginning. When we talk about Chiari malformation, generally we'll be talking about the type 1. The type 2 is also the other thing. From Dr. Miller, I learned very specific about how you talk, and you didn't call it an oral Chiari malformation is type 2, period, because that's the way that it was described, and that's usually associated with mild meningeal or spina bifida, and that would be another hour added to the talk if I were going to talk about that. And these other two, let's not worry about those, because we generally don't have to deal with that. In fact, they're initially described by Dr. Chiari, but we really don't consider them in the same vein nowadays. So the type 1, the Chiari malformation, that's what we're going to be talking about. It's not a very common disorder, about somewhere between 1,000 to 5,000. We don't even know how many people really do have it, although we're getting a better idea. I remember when I first started working on this, these were popping from everywhere because that was about the same time MRI machines were becoming commonplace. So people were getting these scans with a Chiari malformation and nobody knew what that had to do with. And it's actually a little disheartening that we're still hearing the same things nowadays as we were 27 years ago, which is the Chiari is not your problem, you're just crazy. Times change very slowly, unfortunately. Most cases are sporadic, but we do know that there's a family inheritance. It's usually recessive, although sometimes it could be dominant. And it's generally understood as a unbalanced development paraxial mesoderm posterior fossa. This paper, which was published in 1999 by Miller, this actually really fundamentally changed things for Chiari patients. Because this really provided a template with which physicians could use to really understand the symptoms of Chiari malformations. Although Chiari malformations have been described quite some time ago, when MRI machines became more commonplace, it became obvious that the traditional thinking of Chiari malformations and the symptoms they're associated with were different. And he really developed this by listening to patients and listening to their symptoms. And I think more than the paper itself, it's the message that it really shows is to listen to the patients. But the most common presenting complaint is a suboccipital headache with neck pain, weakness, numbness, loss of temperature sensation. The most common presenting sign, which is something that we see on physical examination, is a hyperactive lower extremity reflexes. But this is a busy slide, and this is meant to be busy because this is exemplifying that just about any neurologic sign or symptom you can think of actually can be attributable to a Chiari malformation. And the real art is determining, when you're seeing a patient, what is related to the Chiari malformation and what is not. So what is a Chiari type 1 malformation? This red line here represents the foramen magnum, which is the hole at the bottom of the skull. And anytime there is any penetration of the cerebellar tonsils through that hole, that's considered a Chiari malformation. It also can cause, the brainstem is here, and just to orient you, the white is spinal fluid. This is the spinal column in the front and in the back. And you could probably get the impression that this bone is compressing a little bit onto the brain here as it is from behind. You can have hydrocephalus, which we're not going to talk about because that is also another 1-hour lecture. And syringomyelia, or cavitation of the spinal cord, can develop as well and is associated with Chiari malformations. We'll talk a little bit about that in a bit. Another tidbit of information that we need to deal with in the pediatric population, that the tonsils actually ascend as we age with growth. So in terms of having an absolute, measurement number for pediatrics, it's somewhat of a moving target. In adults, the tonsils usually do not descend below the foramen magnum, but the general convention that we ascribe to is about 5 millimeters of the tonsils descending is considered a Chiari malformation. We talked about the Chiari IIs and the Chiari Is. Well, there is a Chiari 1.5, which actually is somewhat significant, and it's sort of between the Chiari 1 and 2, where, as you can see, this is where the brainstem ends. And in the Chiari malformation, we talked about you're only supposed to have the tonsils that go below the foramen magnum. In the Chiari II, you actually have the lower part of the brainstem that sticks through that. And when we start talking about complex Chiari malformations, that will come into play. So syringomyelia is, as we said before, that's when there's a spinal fluid backup within the spinal cord, and it's got different ways of speaking of it. That you might hear, hydromelia or syringomyelia or just a cyst. But not very well understood, although very well researched. The symptoms that come with it are what's called a dissociated sensory loss, where there's two pathways for sensation. There's vibration and light touch, and pain and temperature. And they're carried in basically different cable systems. So you can have loss with one without the other. Usually it's the pain and temperature that goes. A central cord syndrome, where the arms are more affected than the legs in terms of motor scores. And that's because as the tracts come down from the brain, they're more on the outside of the spinal cord, whereas they're going from the brain, they're going out at a particular level. They're more centrally located as they cross. So think of if you had an exit to a highway where the through the left lanes was where the exit, and then you destroyed that, you could have good traffic going back and forth, but you wouldn't be able to have exits at a local level. Brainstem symptoms, if the fluid cavitates up into the brainstem. When you affect the nervous system, it affects bone growth, so you can have scoliosis. And certainly when you affect and destroy pain pathways, it could lead to chronic pain. There's a Chiari 0 malformation where this exemplifies it fairly well, where you really don't see tonsillar descent, but as we talked about before, you don't really see much spinal fluid back here. It looks like a tight posterior fossa. The initial description was with this tight posterior fossa with syringomyelia, and patients can improve in those certain circumstances with decompressions. So now we're going to switch gears to connective tissue disorders. The one we talk about most, EDS or Ehlers-Danlos, and I'll pretty much stick to that. I won't get too much in the weeds about the other ones. It has a similar prevalence actually to Chiari malformations, and it's a disorder of connective tissue, and what's affected are the collagen fibers. And what it generally leads to is joint laxity, soft skin, easy bruisability. In more advanced cases, there are certain subtypes that you can have vascular fragility and internal organ fragility. It's been classified and reclassified. This is the current classification, and you can see, these are all autosomal. Some are the most important ones are actually recessive, and what I'm showing you here is it's a problem. It could be a problem with how these collagen, these protein fibers are organized, how they're put together, or how they're cross-linked, because there's 3 of them that get linked together. The most common type is the hypermobility, which is what's called type 3. And the problem with that is, patients go for genetic testing on this. So all these other ones, we know what the gene is and we know what the cause is. For the hypermobile type, most of them actually we don't know. So you go get your testing and you're most likely to come back with a diagnosis of we don't know. And although there is another subgroup that has, which is kind of interesting, and what's interesting about it is this TNXB, which no one's really sure what that really deals with. It's very close to this gene. What is that gene? Well, that gene is involved in steroid synthesis, 21-hydroxylase, and if this is disturbed, you can't make cortisol or corticosteroid or aldosterone, and it leads to a condition called congenital adrenal hyperplasia. So it's kind of interesting where you have this interplay of the EDS patients and an endocrinologic disorder. And here's the start of the thread in the talk here. We're going to start to see that there's lots of different organ systems involved, and from a medical standpoint, there's lots of different subspecialties beyond neurosurgery involved in these patients. So the big thing is joint laxity. And there are a lot of, we can subjectively assess this, the range of motion and how much hyperextension you get, how stable joints are. But this Dr. Byton came up with the scale. It doesn't assess all the joints, but it's a very good screening tool. And I'll go through it. There's 9 possible points you can get, and generally the Byton screening is considered positive for hypermobility if you have 5 or more. You get 1 point each for both of your elbows if you can hyperextend your elbow. And you get 1 point each if you can hyperextend your knees. And if you can bend your pinky finger back, that's another point, and you get another point if you can do that with your thumb. And if you can palms to the floor, knees straight, you get another point for a total of 9. Caveats being, as we age, we lose our flexibility. So children tend to be very lax, and maybe a 5 or a 6 isn't enough to classify for a kid. But if you're a 5, an adult, it really does nail things down more. Females tend to be looser than males. If you have any sorts of trauma or surgery on your joints, that affects it. I'll go through this really quickly, but the classical, type 1 and 2, you have the hyperextensibility of the skin, joint hypermobility. These patients have lots of sprains and dislocations, and they have poor wound healing. The type 3, the big difference is there's a lot of degenerative joint disease and premature osteoarthritis and pain. They do have heart problems with prolapsing of the mitral valve and aortic root dilatation. And this is the one that everybody who gets genetic testing prays that they don't get, the type 4, because you have fragile blood vessels, thin translucent skin. This is sort of like the characteristic of the skin that people get. It's the most dangerous, and we'll go into that a little bit in a moment. So soft skin, doughy, hyperelastic, and these are some examples, just pictures so you guys can see this. You get skin fragility like the back of the elbows there. You get these what's called musculoid pseudotumors, where the fat, because the connective tissues are actually kind of weak, they can actually poke through connective tissue layers in the skin, and scars do not heal very well. So the difference between the classic and the vascular, you have wound problems, soft tissue fragility, but in the vascular type, you get artery and intestine disruptions. A lot of these patients have a very shortened lifespan. So very busy slide. Bottom line for this is this is really geared more to medical folks, but any type of condition that has connective tissue problems, can be mistaken or in what we call the differential diagnosis for Ehlers-Danlos syndrome. With respect to kids, when is it appropriate to think of EDS as a diagnosis? With late walking, with joint hypermobility, easy bruising or bleeding, any child who just ruptures a blood vessel or an intestine without any explanation needs to be workup for this. Also, recurrent joint subluxations are also a time that we need to consider this. Now, again, pointing at how many organ systems are involved with EDS. It's not just orthopedics and neurologic. You can have some dental issues, cardiac issues, pulmonary, issues with your throat, so ENT and GI. This is not a job for one person. Now, moving into some of the other things, more neurologic issues with connective tissue disorders, there are a lot of headaches and syndromes. Migraines are very common, and basically cervicogenic headaches, neck pain. It could be, that is where neurosurgery sometimes gets involved, because you need to consider instability issues. Of course, when you're in an adult population, sometimes it's caused by problems with disc disease that are initially caused by the joint laxity and the wear and tear on the joints. I'll skip over that. We did mention hydrocephalus before, but you can also have low pressures in the brain. Women sometimes experience this as a complication of epidural blocks during pregnancy, where you get a spinal fluid leak. But what predisposes connective tissue disorder patients is the connective tissues in the coverings around the brain, the dura are lax, and you can get these outpouchings. Again, this is the spinal cord in the middle, and the white is a spinal fluid, and you see these little sacs here that's caused by weakening. And those can rupture, and you can have leakage of spinal fluid, which leads to headaches, which tend to be worse sitting up there, so they're positional. Also is dysautonomia. This, because the blood vessels are so lax, it does affect the autonomic nervous system, and people can sometimes, upon moving from supine to standing, dropping in the blood pressure, which decreases the blood flow to the brain and can lead to lightheadedness and dimming of vision. They also can get what's called a coat hanger type of headache, where, as you can imagine, it goes through the neck and the shoulders. And this is just putting that whole stuff together, really as a decision tree. You can see how complex this actually is. So let's put all this stuff together and talk about Chiari's and connective tissue disorder. This first came into consideration in 2007, where Dr. Miller again described this association between connective tissue disorders and Chiari malformations. One of the things that he noticed is that there were what he called functional instability, that if you just took an MRI or X-rays in a lying position, everything looks okay. But if you actually sit patients up, or if you change the positions, you'll see some dynamic component. Here we see some separation, and which you can reproduce and actually improve symptoms in traction. Here you see the joint between the skull and the top of the spine sort of shifts back, which you can put into place with traction. And this led to the notion that we can help these people by fusing them if we see this. And certainly people do get help with this. However, no outcomes were ever produced. And I think that's really the troublesome thing about this, because it did spur a lot of people getting a lot of neck fusions, and there are some unintended consequences to that. And where my concern is it's also applied to the pediatric population, where you also always have to take into consideration growth and development. Now, certainly we fuse patients who need it, and you accept those issues about the unintended consequences of growth and development. But when it's actually not entirely clear that you improve an outcome, I think you need to be a little bit more careful. He noticed that association in about 12% of his patients. There was an overlap, which was kind of astonishing because people had never seen that before. Now that 12% may be a little bit of a bias because of the types of patients that he was seeing, so maybe oversampling the general population. But we do know that there is an association now, and we also, through his work, realized that there is a genetic component to this. Now we'll get into the complex Chiari malformations, which, I look at something like this. I see, this S shape to the spine, to the brainstem and the spine, and all this going. It looks complex. It looks very difficult to take care of, and I'm sure stuff like that scares a lot of parents and a lot of doctors. But we can actually define this a little bit better, and we've had a lot of help along the way. The first one was in what's called the Grab-Oakes line, and what they described in their paper is between the bottom of the skull in the front and the back of the second vertebra, you draw this line, and then perpendicular to it, you draw it back. And this is what we call the PBC2. And what that really is doing is providing a measurement to how much compression you have from the front of the spine. Because up until then, we were all looking back here and just taking care of this. And in their paper, what they showed is that if you had more than 9 millimeters, you were more likely to have problems over time and need additional operations, whether it was a fusion or actually going through the mouth and having that bone drilled out, which is called an odontoidectomy. Dr. Henderson described something called the clival-axial angle, CAA, which is the measure along the clivus, that's the bone in front over here, and the back of the spine. And that can be very dynamic. And he did some computer modeling and showed that as this angle gets steeper, that you start to put more stress and strain on the spinal cord, which can actually cause neurologic symptoms, and show you can reverse or improve neurologic symptoms by basically reducing that angle and fusing patients in a new position. So now that we've talked about all the different problems, how do you treat these things? Well, migraines you treat with various different migraine medications. Certain blood pressure medications may actually have been shown to be helpful in Marfan syndrome, which is sort of like a cousin disorder to the connective tissue disorder. So it'd be interesting to see if that works with EDS patients as well. When they're neck-mediated ones, that's when we need to look and make sure patients are not unstable. And there's other things that we can do, whether it be nerve blocks and what have you. For the dysautonomia of the POTS, beta blockers, which is a blood pressure medication, tends to be good for both the headaches and the blood pressure issues, and things like support stockings and different medications also treat this quite well. Intracranial hypertension. Usually the primary treatment is caffeine and hydration. We can do an epidural blood patch, either just in the lower part of the spine, but we can do targeted ones, and we can do direct surgical repair. This was a patient who resorbed part of a craniotomy that he had and was having low pressures, because I actually measured them, and what we did is we actually repaired that hole and did a cranioplasty and basically closed the skull and improved the pressures, and he did much better. So this sort of is getting into a little bit more of my newer thinking on things, and hopefully we can take this into a better direction. But this issue with joint instability, there's a lot of data and a lot of studies done in the orthopedic literature on patients with EDS, with subluxations and different joint problems. And the spine's multiple joints together. And we know a lot of the problems that these EDS patients have is the same reason why, people pop their shoulders or in their knees with EDS, is because the soft tissue is more stretchy than it should be. So that leads to problems in the neck. And we know from the orthopedic literature, the direct surgical treatments aren't all that good. It's almost a treatment of last resort. So shouldn't our approach to the cervical spine in these types of patients be similar? And I think that it is. I think the most important thing that we can, so we start off with conservative treatments. And what you're trying to do with these treatments is increase joint stability. So as we're trying to do physical therapy, we're not trying to make people stronger, we're trying to increase the tone of the muscle. Because that's what stabilizes the joint. You don't need strength, you don't need to look like Arnold Schwarzenegger. That's actually going to pop more joints. So lower non-resistance exercises are good things to do. You add repetition, and you just do more, slowly add things on. And the idea is that you have to, it's not a sprint, it's a marathon. And muscle spasms, lots of different good treatments, heat and massage and TENS, acupuncture. My approach is the kitchen sink. Try whatever works, and whatever works and is helpful, you go with that. Medications like muscle relaxants probably ought to be avoided because, again, you might get relief of the spasm, but if you go too far with it, then you're starting to decrease tone, and that's going to work against what you're trying to accomplish ultimately. Back again to listening to patients. It's important to know what the root source of the pain is. Is it a myofascial spasm? Is it neuropathic? Is it degenerative? You treat those types of pains differently. And on top of that, particularly when you're dealing with chronic pain, there's an entity called central sensitization. It was first described in patients who had pain syndromes following strokes or spinal cord lesion, and then researchers ultimately realized that anytime you have some sort of neurologic dysfunction, it could lead to chronic pain. Basically, what you're dealing with is the gain setting for pain is set too high. And let me show you some illustrations. This is for normal sensation. Again, we talked, there's two types of path. We have pain and we have, let's say, vibration types of sensation. And when the pain receptors are stimulated, there is a little sort of gating neuron in the spinal cord which will block the touch receptors from firing so you can feel pain. That's also the scientific explanation why when you rub something that hurts, it feels better, because your spinal cord can't process both signals at the same time. And so the same thing with touch. With central sensitization, for reasons we don't necessarily understand, one of two things can happen. You don't have that gating, so there's no local control. So all this painful stimulation goes straight up to the brain. And we call that hyperalgesia. There's actually an even worse situation called allodynia, where there's sort of like, you get crosstalk, where a touch sensation will cross over into the pain pathways, and that wisp will actually feel painful. So these are all consequences of chronic pain. Medications that are good, anti-inflammatories, lidocaine, muscle relaxants, we just talked about that. Neuropathic pain control, anti-seizure medication, tricyclics, which are used for depression. Those are all good for controlling this pain because it affects the brain chemistry. So perhaps some patients have, there's a stigma. You're giving me an antidepressant, you get an anti-seizure medicine. I don't have those things, but it's affecting the brain chemistry in a very positive way. Opioids, there's a lot of press about that, and we have a lot of issues with. It's a terrible drug for this, because if you look at the brain chemistry, things that increase the sensations of pain, they're all upregulated in this condition, and things that inhibit are downregulated. But your opiate receptors are actually already upregulated. So, and your opiate levels are upregulated. So putting more opiates into the system is probably not going to help as much as, blocking some of these things that increase pain sensations or increasing things that inhibit pain sensations. So I'm not a pain management specialist, and that's why you need to have these people involved. But the basic way of dealing with this is a cocktail of medications. Scheduled prevention is more effective than taking things when you're in pain. And many times we can't eliminate pain. We can limit it, we can control it. The other issue that always needs to be dealt with is the psychology of chronic pain. And it's not that the pain is in your head. The pain is a very real problem, but your emotional and psychological state affect how you experience pain. Pain is really, it's an emotional response to something bad in the environment that interacts with you. And that has a very positive effect. If we remember it, we don't like it, we don't do it again. And many times in chronic pain, and this really applies to EDS and Chiari patients, constantly being in pain and not having any control of it leads to anxiety and depression, and then you get this vicious cycle of it affecting your confidence and leading to negative thinking and hopelessness, and it just cycles you into a bad place. So what really needs to happen is, clinicians need to work with you and really get you to, and we need to partner and get proper expectations. It's patients who have an expectation of no pain, no complications or setbacks, and that they're going to be perfectly, or, as far as I do not tell people that I don't make, that's what patients, when they come to see me, they want to hear, that their pain's going to be gone, the surgery is going to go smooth and it's going to be great, and they're going to be back to where they were. I think that's very difficult to do and many times impossible. I think goals need to be realistic. We'll make things, if we can give you no pain, great, but we're going to make the pain less. It might be a bumpy road. We might have complications. And quite frankly, if you've had once you start having more, once you get past that first surgery, it's more likely that the road's going to be bumpier with each subsequent ones. And the goal is not normal activity, but improved activity and improved quality of life. And that relationship must be centered in the fact that the physician validates that your symptoms are real, but the patient also has to realize they play a part in it. We're a fast food kind of society now. We want to get something now. We want a pill to make everything go away. It doesn't work that way. And sometimes counseling, is very important. Some patients don't have the proper tools to emotionally or psychologically deal with what's going on with them. And being given those tools is important as being offered a surgery as giving a pill. So things like cognitive behavior therapy and relaxation and hypnosis, all those things can very much help patients feel better. So, surgery. What if we really need it? So, just to quickly go over the Chiari surgery, the decompression. Here's the back of the skull. Essentially, we're taking off a large piece of bone here from the back of the skull. Here's a little depiction of the spinal cord underneath the first cervical vertebra, and we take that off as well. And that's the basic gist of it. There's a lot of different variations. You know, whether you open the dura, I do, and I got some video of what I do under the microscope when the dura is open. Some people open the dura completely. Some people open one layer of the dura. When you open the dura, some people close it, they leave it open, they sew different patch grafts in there. It'd be interesting to see which one really does actually work better. But I can show you a little video of this if you like. I think we're actually I'm going a little faster than I anticipated, which I think is very good. I'm going to be happy about that. So here we have the dura open, and this is the second layer of coverings on the brain, the arachnoid. There's a third called a pia, which is stuck to the cerebellum normally. And here we have the cerebellar tonsils. And what you can see here is, as I open things up, there's not much pulsation of the cerebellum here, and everything sort of looks like it's squashed down. Here's a brain stem here, lots of blood vessels here. So this is, I think the other thing I want to point out is, you know, this sounds like decompression surgery, but in the wrong hands, you could actually do some pretty significant harm to a patient. And what I also want to point out is, as I'm working through here, you'll see that there's some little it almost look like spider webs. That's why it's called arachnoid. But you'll see that some of them are very taut. And you see that white discoloration? I went a little fast. That's from poor blood flow from chronic compression of the tonsils in there. Now, as I move through, this is what I want to point out. See how this instrument has a very sharp edge to it. And I'm pulling on this thing, and I'm actually going to have to take scissors to cut that. And I see this time and time again when I do the dural opening procedures, and it reminds me, you know, how likely are you able to get a good decompression by just removing the bone and leaving the dura, and not doing this because of how tight these little things are. And I want to draw your attention. You can start to see now the cerebellum is pulsating a little bit more. It looks a little bit healthier. And I don't have me sewing in a graft. That would be boring and very tedious to watch. The good thing about that is when you choose patients properly, the likelihood of resolving symptoms, if you choose those symptoms properly, 80–85%. When you do the decompression for syringes, that's the plural of a syrinx, 90% of the time you get a decrease or resolving within 6 months. The important thing is the less typical the pain is, the less likely the surgery will be effective. So we're going to get into, we're coming towards the end, and now the whole idea about fusing these Chiari patients, these complex Chiari patients. So Dr. Brockmeyer did this study, looked back on his patients that he had treated and looked at the ones that he fused because they ended up with evidence of instability or they had neurologic problems, not necessarily because they had neck pain. And what he knows is those Chiari 1.5s was statistically significant. Those were more likely to need surgery. Basilar invagination, we haven't talked about yet, but that's the top part of the spine when that sort of goes up into the skull. And it kind of makes sense that those patients would be more likely to need fusions because you're more likely to compress the brainstem with that. And when this clival axial angle was less than 25, you know, much like Dr. Henderson predicted with his computer modeling, they were more likely to have problems and need fusions. But what was interesting is that PBC2 line really wasn't statistically significant. So at first in our literature, we thought that was a significant issue to be concerned about, but now we're coming to find that it really isn't. And you can have a lot of that retroflexion of the odontoid. It may not really be an issue. The other thing I want to point out is, and I want to show people, is, you know, we talked about the Chiari 1.5s and these clival-axial angle patients needing fusion. But if you look at how patients do over time, it's not like they need to have this fusion right then and there. They're not necessarily, just because you have those things doesn't mean you need surgery. And in fact, a lot of these patients took 2, 4, 6, 8 years out before they needed surgery. So there's a lot of evidence to suggest that it can be done on a wait and see basis, and maybe particularly in children who have growth and development, fusing their spine's not an innocuous thing, and maybe we can wait. And then of course, if you're going to do something, what are you going to do? Are you going to put screws in the spine and just leave patients the way they are? They're real little kids, we can't put screws in. We have to wire little rib grafts in. And are you just going to fuse them in place? Or are you going to, as Dr. Recat described, you're going to sort of pull up on their head and straighten out that angle? So these are answers we don't even really have at this point, and hopefully we'll know in the future. I just know from my personal experience, sometimes less is indeed more. Here's a patient, here's a complex Chiari, most definitely, and she's got a pretty steep angle over here. But we basically fused her in that position, and look at the difference that you have here. We have her cerebellum nice and decompressed. Her brainstem looks straight now, and we really didn't do much in front there. And another cautionary tale is a patient who I was involved in, who had a good decompression, was having some neck pain, and some other well-meaning surgeon decided to do a fusion on him. And what you could see here is he's nice and fused here, but he's now angulated over here. So again, with these EDS patients, the connective tissue is weak. You start fusing levels together, you start putting more stress on other levels. And I tried to do it simple. I tried to fuse him from the front there, but he started actually separating back here. This is what he ended up needing. The other thing which I've recently started thinking about is, again, when you have a spine fracture, the bone needs to heal and we need to fuse things, and this kind of approach makes sense. But for what we're dealing with the EDS patients, where the problem is not a bony problem, it's a connective tissue problem, should we actually be doing a bony fusion? Is there another way we can fix this that doesn't require fusing bony segments, putting stress on additional levels and causing problems later on down the line? This is a little bit of an acute example, but this can easily happen to anybody, any child who's had this. Is there a better way we can do this and at the same time maintaining mobility? I actually think that there is, and hopefully I'll be talking about that at some point in the future. So the slide everybody I know has been waiting for, the conclusion, that when you have Chiaris and connective tissue disorders together, the management really gets complicated. But understanding the root cause of each of the symptoms will likely help you improve patient outcomes. And the neurosurgeon is not the end-all and be-all, because not all cases are amenable to surgical correction. And the best way to have a Chiari center is to have a multidisciplinary approach where it could be a neurosurgeon who's in charge, it could be somebody else, but where we take an approach where each aspect of the patient is taken in part, but then we treat the patient still as a whole. And that's all that I have to say for tonight. Does anybody have any questions after that?
So we now have a Chiari center here, or is that something that we're trying to get started?
I would like to move towards that. We see Chiari patients. We're known as a place that patients come to for Chiari because of my background, and it's not just myself. Our neurologists, have sort of bought on to this to a certain degree. Our rheumatologists. We have a pediatrician who's a mind-body specialist, Dr. Pendergrass, who deals with cognitive therapy and hypnosis, and he's bought on to this. But have we gotten into a point where we've all sat down in a room and said, yes, let's build this together, this is going to be a formal thing? No, we haven't done that.
To move towards having a Chiari clinic, like we have the pediatric craniofacial clinic, so that they can see everybody on the same kind of day? Does that make sense when you're talking about multidisciplinary?
Well, multidisciplinary in the sense, it is good when we see patients. Sometimes it's not possible to see everybody in one day, but the craniofacial type of clinic is a good model, but it may not be so good with all these complex cases. But you can sort of have a virtual clinic, and we're really, the good thing about this institution, everybody's here. We see patients in the hospital together. Our clinics are all basically down the hall from one another. We have each other's phone numbers. Our offices are close to one another. So it's not like you have to go across town. Some of the challenges of doing this is the amount of coordination that it takes. And not just scheduling the clinic, but also scheduling tests and clinic. And this is something that, the mindset here at this institution, this is not the Cleveland Clinic, this is not the Mayo Clinic, who've done that beautifully. As I've told some people here, this institution, we've had a changeover in leadership, and I think in my dealings with them, this is where they want to go to that next level. Are we going to be the Mayo Clinic? No, but the whole philosophy of integrated patient care and continuity of care and patient-centered care, which, for goodness sake, in this children's hospital, this is one of the pioneers.
It's wonderful to have
of that. So you can't really have a better place to sort of reinvent, this idea of patient care. But there's logistics involved in that, and there's a lot of there's a culture at the institution in which really needs to change. I mean, the institution really, this is, the children's hospital that really was the arm of this medical center, which started as the Talmadge Memorial, basically the county hospital. And a lot of that, which is rooted in teaching residents and taking care of, underserved patients. And that's great. And that's a kernel part of the mission. But we need to help them better, we need to expand past that and find ways of helping people, find ways of getting people to come here who can't get the help that they need where they are. And I think we're heading in that direction. We'll see what happens over the next 5 or 10 years.